Let me just open this thing.
In the presentation to this House.
Honorable
Thank you, Chairperson of the session. Minister, you have highlighted that provincial hospitals, they do have backup generators. What I want actually being placed due to the budget constraints. Thank you.
Thank you, Honorable Malitsane. Honorable Gillian, you will be the next. Honorable Gillian.
Thank you, Chairperson. Greetings to the Minister, MECs, and the Department. Chairperson, I want to know from the Minister, which provinces have been greatly affected by the load shedding crisis, and what impact did it have on the livelihoods of those citizens?
Thank you, Honorable Gillian. Honorable Baha.
Thank you, Deputy Chair, and good morning to the Deputy Minister as well. Deputy Chair, I know that the Minister did touch on this part, but I think that I should raise the question as such. When load shedding occurs, many public hospitals lose ability to provide proper healthcare services. Even though some do have generators to provide shedding, while the rest are still burning fuel to provide healthcare services to the communities they serve. When will the Minister yield to what the DA has always been requesting, to have all hospitals exempted from load shedding? DM, how are meetings with ESCOM yielding positive results to address this? And has your department applied to ESCOM to get all hospitals exempted from load shedding, including clinics in rural communities? So are there any plans to ensure that there's access to healthcare in all different communities? My second question, Chairperson, is that sorry, is that to what extent has other services like pharmacy, laundry, sterilization, hospital catering, and the cold chain been affected by load shedding? And how is this being mitigated? Thank you, Deputy Chair.
Thank you, Honorable Baha. Next will be Honorable Nchabeleng. Nchabeleng.
Yeah, thanks, Chairperson. I just want to check for myself, what will be the role of public works in the implementation of this program that we intend rolling out in hospitals? And then the issues related to the speed at which public works do their things. And the other is, have we thought about security of whatever we're going to put into our hospitals? You know, mitigating against things like crime and all that. And then how much is this study going to cost? Like, you're setting up a team that is doing research to check how we're going to do this and that. How much will that cost? Against, if you say, I mean, I know of areas in Limpopo where because of load shedding, people have moved from ESCOM. I'm not a business in Limpopo hotel that have moved from ESCOM to using LCD batteries and solar and all that. Do we really need this study to discover that this thing works? And paying such a lot of money when the money could be going into the program itself. That's I'll need to be educated on that one. Thanks.
Thanks, Honorable Chamberlain. Honorable Christians.
Thank you, Deputy Chairperson. My question is obviously about the operational generators. Minister, in the case of a total ESCOM collapse and a complete blackout or severe load shedding stages, all hospitals will obviously be affected. How are you ensuring that generators at all hospitals are fully operational? Then, Minister, what provision have or are you making for additional diesel procurement to ensure that ventilators and other life-saving equipment can be sustained during such severe load shedding? Is there sufficient allocated funding for additional diesel? To what extent has load shedding and subsequent diesel purchases increased the day-to-day costs of running hospitals and the patient day rate? And lastly, Minister, have you set guidelines on the required quantities of diesel or fuel reserves for different levels of healthcare facilities to ensure that they are always in stock? Thank you, Deputy Chairperson.
Thank you, Honorable Christians. Honorable Ndongeni.
Thank you, Deputy Chair. Morning, Deputy Minister. My question is, what is the current capacity of health facilities to have backup energy? And is the current capacity to be sustainable? Thanks, Deputy Chair.
Thank you, Honorable Ndongeni. Honorable Mutsamai.
Thank you, Deputy Chair. Thank you, Deputy Minister. Noting the devastating impact which power cuts have on hospitals and clinics across all provinces, on which day can we expect that all healthcare facilities in the city of Johannesburg, including the smaller clinics, to be expelled from load shedding?
Thank you, Honorable Mutsamai. Honorable Malika.
Thank you. Thank you, Deputy Chairperson.
Yes, you may continue.
Okay. The question that I want to ask to the Deputy Minister, is the backup power in health facilities sufficient to all health equipment, storage rooms, and diagnostic machines? Thank you, Deputy Chair.
Thank you, Honorable Malika. Honorable CF Beyer-Smith, you are the next.
Thank you, Deputy Chairperson. Am I audible?
Very much, thank you.
Thank you so much. Honourable Minister, South Africa are known for the great care they take with their deadly departed. Yet, we hear of horrific stories of bodies decomposing in mortuaries due to load shedding. What urgent measures will the Minister take to avoid this completely unacceptable state of affairs? Thank you.
Sorry, I struggled to unmute. Minister, whilst I just want to add to the question of Honorable Smith, and what are we doing to assist the private mortuaries that are possibly also experiencing the same problems? Just to add it to that question. Then now it will be Honorable Nkosi.
Thank you very much, Honorable Deputy Chair. Greetings to your good self and the Deputy Minister. Deputy Minister, my question is one. Before the current load shedding crisis, did health facilities have sufficient backup energy? And what type of capacity existed? Thank you very much, Honorable Deputy Chair.
For now, it was the only questions. I just want the members, if you have any question, ask it now if it is for the minister. Otherwise, we will wait for later. Honorable Ryder. Honorable Badnos, you have asked. So we will just give Honorable Ryder.
Thank you very much, Chairperson, and thank you to the Deputy Minister. Just struggling with load shedding here at the moment. So yes, I just got thrown off and I'm back on now. The analysis by the Deputy Minister, yeah, gives some insight, but I think it may have been a bit superficial. So load shedding doesn't only affect doctors, nurses, and caregivers in hospitals and clinics, but first responders are reporting massive delays in the traffic due to the non-operational traffic lights and the resultant congestion. Now, delays in first response causes complications in the subsequent treatment of patients down the line and can even cause death. So, Minister, as we take a moment to respectfully remember the lives lost because of the time it takes for ambulance or paramedic to get to a patient, there are two things that I would like to ask. Firstly, what support are you offering to the traumatized first responders who are starting to feel helpless as they're prevented from doing their work? And then secondly, can you please tell me whether you've budgeted for more ambulances to be placed in the field to reduce response times? I mean, tow trucks and security companies can do it. Why can't we do it with ambulances? Thank you, Chair. Deputy Chair.
Thank you, Honorable Ryder. Honorable Deputy Minister, we will now allow you to respond to the issues as was raised by the members. Please, over to you, Honorable Dr. Clement.
May I check if Mr. Takela is on the platform? TTG, Ms. Janet Hunter is on the platform? Okay, I seem not to have a team from there. Okay, let me start. I don't know whether, Honorable Deputy Chair, I was too fast in my presentation because there are two members. One is Honorable.
Sorry, Honorable Clement. I see Mr. Dakela is on the platform. You said Dakela. I just wanted to bring it to your attention.
Okay, thanks. Then I would have wanted him to start. But let me just start by saying, I don't know whether I was too fast in my presentation and maybe some of the things I said might have really missed my members. Honorable Nkosi and Honorable Malika, they are saying, is the backup that we have of our generators enough? My first slide was saying not at all. The generators were meant to support us on critical areas like the ICU theater so that we don't lose even a minute or a second because of some fault in the hospital, and therefore a patient in theater cannot be proceeded with. Our backup, all our generators were not meant to support hospitals for 4 hours in the boilers, geysers, and 4 hours of cooking. That's what I was meaning, that the backup, the generators were meant for a specific intervention so that we do not lose life. So if there is a faulty electricity there, yes, you could then be able to actually go and adjust the fridges in the pharmacy and make sure that maybe after 30 minutes, we have not lost too much, the temperature has not gone down too much, but it's not, now you have to really get to being supporting. So I'm already answering the member who was saying, what do we do with the sterilizing machines, with the sterilizing units, with the pharmacy? All those were not meant to be supported by our stopgap measure of a generator because absence of electricity for 20 minutes, 10 minutes in a hospital may not affect that much a fridge in the pharmacy. But this time around, if it is 4 hours, then you are going to be affected. That is actually also answering the question of the member who was actually raising there. Now, I don't know how to answer. We do not have deaths in our hospitals classified as a death due to load shedding. We don't have that. All we are saying is that the absence of electricity is compromising the quality that we give. Starting from what Honorable Rada is saying, how quickly do we get patients into hospitals because of the ambulance delays, in the robots that are not coming in. That part we are not yet able to quantify, and we are not there yet to say how much delay do we experience by ambulances not able to come on time due to robots not working and too much of a traffic. Now, honorable members, you probably do record, if you go through the annual performance plans of our department across all provinces, there is nothing that we have put in there to say we will be actually expanding or changing our generators and buying bigger ones. And also all the allocation that you have actually seen that we have been given by Parliament, there's nothing in there that says we will also be buying this much of this. Well, like I'm saying, it's all like a domino effect. If a hospital is used to having 1,000 liters of diesel that sustains them the whole year long, and they have budgeted that for, and suddenly now we are plunged into a situation where we have to have 1,000 of diesel every month, it changes that. It's not budgeted for. We do not even have it in our annual performance plan because we did not actually anticipate it. So something must give in to allow for us to continue buying that diesel. And it's probably going to be in this new budget that is coming in now, probably not offsetting what we already have had in the past, but to say going forward, there is still the load shedding. We need to budget for solars. We need to budget for more diesel. We need to budget for maybe more than one generator per clinic or per hospital because of this and that. So those are issues that, honorable members, you are aware were not part of our annual performance plan because this possibly was not anticipated. Honorable Moletsane is asking specifically about the generators in Free State. Probably if that question can come back again this late afternoon, I may not be able to adequately answer it, but all I was saying that our generators countrywide are needing frequent maintenance and services as they would have needed if we did not have this amount of work. They are now, instead of having a generator needed in a clinic or hospital 2 hours per week and another 2 hours without next week. So now they are needed to use 4 hours almost every day. And that's very different than, therefore, the maintenance cost and the service cost will even be much more. What we would probably say maybe a challenge with is when we do not have enough diesel supply at that time. That may just be an issue now because suddenly we have a lot of demands for that. Now, I don't know, Honorable Bach, your question where it comes from, because it's a government plan, not what we have borrowed from Honorable Bach and the DA, that all our health facilities should have generators. In my opening remarks, I said, historically, even before load shedding, this has always been our plan. This has always been our policy to have all our 24-hour service health facility supported in the event that there's just a small fault and we have not to lose those. So it's not something that we have learned from this part. So what we are saying now, what we already have is already to be augmented because we now have continuous load shedding. And I've also answered a bit on what we are raising, that is pharmacy, CCSDD, those that are actually sterilizing and pharmacy, that one now must be accommodated. So the plan and the plan I've outlined is saying we have been given 76. We had sent a plan to have 213. We would have wished to send more. And I did raise the constraints why not all 213 have already been actually been given to us. Honorable members are asking, have we budgeted for this? No, we haven't, because this is a new phenomenon where we have frequent load sheddings. And I'm saying reflect that on our annual performance plan. We didn't have this budgeted for so much of diesel, so much of this. So we are now as going to be supported moving forward was this plan I'm saying, whether we're discussing the CSIR, whether it's 250 million of the 46 additional hospitals with NCOP, all that is actually to be fine-tuned, presented to the National Treasury, and they would then be looking into our plans and indicating the availability of funds here and there. So I am not also able to answer which provinces, I would not be able to say which provinces have been affected the most, but it will make sense to say provinces that have got high volumes of patients. There are provinces that still refer, and there are certain, when you refer to those hospitals and it's critical patients, there are certain hospitals in this country that should not go without electricity even for a minute. Even if you do in a smaller clinic, they afford not to have it because probably there's even no delivery taking place there. They need it for maybe just sterilizing and lights. You may forego that, but there are certain facilities. I may not be able to answer that well, but maybe Mr. Takela will answer. It will make sense to me to think that provinces like Gauteng, those with big central hospitals, Free State, KwaZulu-Natal, Western Cape, will probably are the ones that might have a higher demand of such, especially largely some of them, and Eastern Cape was the volumes, I mean, even the population of those, and also the burden of diseases in those provinces will be one of the issues that will actually say this much to us. Now, I am aware there's a parliamentary question that has come in with regards to mortuaries and how are they coping, and I could remember well as we were actually answering it yesterday. Provinces are planning this way. If there is a mortuary in the central part of Durban that actually is better off than the one that is in Tongat, so the department will err on the side of moving more bodies from that outlying affected mortuary by load shedding to the center, and therefore have to make this one to actually do much more than before. But number two, the program of also bodies not being claimed fast enough. You know that there are certain people who actually passed on and the relatives are too difficult to trace, and they go on for, we have to keep the bodies for 30 days and then also deal with the bodies as paupers. But sometimes we err on the side of keeping them a bit longer, tracing the relatives, and therefore bodies might be piling. But what I now know, during this crisis of load shedding, provinces are rearranging such that their forensic mortuaries, those that are almost continuously having a strong support of electricity, are now loaded with more bodies than those that will have a challenge, so that you can have a less and less decomposing bodies. Now, if you were to ask us as a department, what are we doing with the private mortuaries? Now, private mortuaries are businesses. It will be very difficult to expect us as a department. Maybe then it will be a matter of government support. So I will not be able to give what are the support from the small SMMEs that is given to up and coming smaller mortuaries when they are facing with this part. We are also dealing with our lot and making an arrangement to move bodies as well as and when we notice that it's better that side than the other side. Mr. Honorable Rider, did we budget for, if you budget, I've always, if you budget for a new ambulance, it's an ordinary vehicle with equipment that is worth 700,000, and the vehicle that was already 500,000 worth becomes a 1.5 million worth of a vehicle because of equipment, and also having to employ 8 other people to run with it. So it's not an easy thing, budget for more ambulances, you have to give in from other areas. So I will not be able to comprehensively say, have provinces budgeted for more ambulances? Yes, they may, but if they do so, they must let go of other programs or of other issues because of the fiscal constraints. It's not like we now see a crisis, and therefore it's easy to make a decision. What do you switch off to actually get more ambulances? What do you switch off in terms of buying a bigger generator than what you already have? Now, if Honorable Mutsama is asking by when should we have all this in place, we are having a budget speech tomorrow, and there will be an issue of allocation. But again, it depends whether we have sent a very convincing report or a plan to the National Treasury that they are looking into and say it is needing funding. But we are really way ahead in terms of the work having been started. They already have got ideas and feasibility showing that we will need this type of a solar panel, then a household will need it to be serviced this often and all that. So all that is to be finalized in costing, but again, it will go into that big pot, and therefore it will come out there. So it's not easy to say by what date will we have all this. I'm projecting according to if our plans that we have put in are accepted and which we are completing by April. This presentation I made is projecting that this should start by June to see the impact of what we have projected. I might have left out, that's why before I started, I needed to know who are the officials who are here. I know the head of infrastructure, now I'm informed, is here, Mr. Takela, who's technically much more clear than me in answering some of these specifics. He's our head of infrastructure, who's also on a day-to-day discussing with the CSIR. Maybe I can allow him to add on some of these things that I've said. Honorable Babu Takela.
Mr. Takela, as requested by the Deputy Minister, you may continue to respond.
Thanks, Honorable. Good morning, Honorables, and good morning, Deputy Minister. Deputy Minister, you have covered almost everything. I wanted just to cover the study that is done by CSIR is intended basically to identify critical areas for all the health facilities and quantify the required size of the solar energy. That's the objective. We want to make sure that later down the line, no one is going to be asking, how did you define the size of solar energy for a clinic? How did you come up with that size of solar energy for a CHC? And also within the CHCs and clinics, there is an issue of theft. We want also to accommodate that. What is the best energy, solar energy that can accommodate clinics and CHCs? We are also looking at the different types of inverters that can be stored in a secured room where they can be burglar bars and stored there so that we don't put solar panels there and then they get stolen. So, but DM, you have covered almost everything. And I think I must also give you an accreditation to become an engineer. Thanks.
No. Please, can you answer on the public works? Honorable Chabeleng asked our relationship with the public works. And I'm happy we have covered a bit on, look, honorable members, we are doing what we can, knowing that there may as well be some challenges with theft and all that. So we will beef up security on this very important equipment. But right now, that plan may not be out. We'll just have to protect all our government equipment like we do to others. But if maybe, with your permission, Chair, could just comment on the public works as asked by Honorable Chabeleng. Thank you.
Granted. Mr. Takela.
Yes, I wanted to kind of like also to highlight that both ourselves and public works, we are working with CSIR. We are both guided by CSIR in terms of how best can we solve the issue of load shedding. CSIR, they've got a huge plant of solar energy that is also there for us to learn from it, and also to make sure that whatever solution that we are putting a solution that is going to be beneficial for the country. I think I'm answering it. I'm not too sure if there's something that I'm missing.
Thanks, you're covered. Thanks. From our side, Honorable Chair, we are completed. We hope we've covered all what the members, honorable members have asked. We might have missed just one or two, we may be reminded, but this is our presentation and this is our response. Of course, it's not complete, it's a work in progress. Every day we engage with ESCOM, we engage with CSRR, we might get a better report next week, next month, but we also have made our submissions and we continue making and improving our submissions to the National Treasury to be considered for these additional budget costs. Thank you very much, Honorable Chair, and back to you now.
Thank you very much, Honorable Dr. Tlomo. I think we still have some questions, but since the MECs is going to be making also presentation, we hope that some of the responses will come from there. Honorable Smith, is there anything that you feel that was not covered?
Honorable Chair, I just want to raise a certain matter. Sorry, am I audible because I've got load shedding now?
You are audible.
Okay, thank you, Chair. I just want to raise something. You know, we're having these ministerial briefings, and I'm concerned there's a tendency coming that it's turning into a deputy minister's briefings, and that is problematic because the ministers are calling for these discussions, and then they don't come to these meetings. I think it is a priority that as the NCOP, we insist that the ministers themselves attend these briefings. It's in essence, it's their briefing. It's not the deputy minister's briefing. Thank you.
Noted, Honorable Smith, and I also request the Chief Whip to take note of the issue as raised by Honorable Smith. We will now have a short comfort break. Chief Whip, do you want to respond on that?
Thank you, Deputy Chair. Under circumstances where an explanation cannot be given, the point of Honorable Smith would hold. But earlier, it was indicated here that when we convene this, they are anticipating that the minister will be here, but the minister is part of an AU delegation that has accompanied the president. So we took that as valid apology that was shared with us. And it doesn't replace is that when we convene this, we are fully conscious that it requires the full ministry's participation. So that explanation called Deputy Chair. And also, we will always strive to ensure that these meetings are attended equally and fairly through the leaders of the departments. But the Deputy Minister has accorded this meeting the dignity that requires the delegation and the substance of issues that he has shared with us here. Thanks.
Thank you, Honorable Chief Whip. Dr. Tlomo, I don't think it's necessary for you to respond on this specific issue because the Chief Whip have clarified that. So, and it's also, I think Honorable Smith is also making a general point that we as the NCOP will be taking up. Unless it's something else, Honorable Tlomo, we will allow.
It's a new matter, Honorable Chair. Thank you very much. I will stay after the break when my colleagues, MECs, are starting their presentations. But at 2 o'clock, I will have to actually leave for the sitting in the National Assembly. I would wish that I would be excused close to 2 o'clock. But for now, I want to listen to my colleagues as they make the presentations from provinces. Thank you very much, Chairperson.
Thank you very much, Honorable Tlomo. It's noted. Thank you very much, Doc. We will now have a short comfort break. And I think it's now almost 11:10. Can we be back in about 10 minutes? And then we will now give over to Honorable Nyambi to continue with the meeting. Thank you very much. Thanks for Dr. Tlomo for your presentation and to the department also for the responses. We will now have that break and give over to Honorable Nyambi. Nyambi, you can determine the time. I just said 10 minutes as a proposal. Thank you.
Your 10 minutes is fine.
Thank you.
Recording stopped. Recording in progress. Recording stopped.
Morning, colleagues.
Recording in
Good
progress.
morning, Baba.
Oh, mama.
Good morning.
Morning,
How are you,
Baba.
Baba?
Fine, how's it, mamas?
Fine.
Morning,
Oh,
Tomo.
mamas. No, let me take this opportunity to extend my greetings to Ntate Masondo, the chairperson of the National Council of Provinces, Mayor Lucas, Deputy Chair of the NCOP, Chief Whip, Ntate Mohai, Mama, Honorable Ngwenya, Honorable MSCs from the province that we represent in the NCOP, representatives of Salga, special delegates, honorable members, ladies and gentlemen. It's always an honor for us, Honorable Deputy Minister Dr. Dlomo, to come together like this, especially when we focus on a very important topic where we're dealing with the briefing on provincial and municipal measures to mitigate against the negative impact of load shedding on provision of health services to our respective communities. Honorable Dr. Dlomo has done a good job in giving us a broader view of the situation of what is happening, what National is doing at national level. And now it's an honor for us to have an opportunity to have our provinces filling the gaps in terms of what is happening in each and every province. And honorable members, already we have started the engagement as correctly represented by the remarks by the chair and the deputy chair that some of the specifics will be attended to. We know, we acknowledge, despite the commitment, Honorable Dr. Dlomo, as you are still part of us, hopefully we might conclude before you can jump to your next engagement, the business of today. Allow me now to indicate that the presentation that will be done by provinces, it's strictly 10 minutes allocated to each province, strictly 10 minutes as maximum. I will do them in an alphabetical order as is always the case. We're starting with the beautiful province called Eastern Cape, represented by Honorable Meth. Honorable MEC, Eastern Cape Meth.
Thank you so much, Honorable Chair. Good morning to you, Honorable Chair, the Honorable Chairperson of Committee and Oversight, Honorable Nyambi. I greet you this morning from the beautiful province. The Honorable Chairperson of the National Council of Provinces, Honorable Masondo, the NCOP Deputy Chairperson, Honorable Lucas, Honorable Mohai, the Chief Whip of the NCOP, the Department of Health, Honorable Deputy Minister, who I believe is the acting minister today, Honorable Dr. Dlomo, House Chairperson, Member Support and Internal Relations, Honorable Ngwenya, Honorable NCOP members, Honorable Health MECs from all provinces, HODs, the DG, senior managers, and all officials on the call. We thank the NCOP for inviting us to brief the Honorable House on the impact of load shedding in the provision of health and care services. It's an important discussion that should be high on all of our agendas as government, business, and civil society and community. The truth of the matter is that since load shedding was escalated to stage 6, more and more of our facilities are under strain to ensure continuity of healthcare services and mitigate any potential clinical risk to both patients and staff. The department has had to and continues to dig deep into its already strained finances so that it can provide continuous electricity power supply, essentially through backup generators. The higher the stage of load shedding, the greater the dependence of generators for electrical supply. or on generators for electrical supply. This current financial year, we are spending about 1.8 million a day, which is 54 million rand a month and 640 million per annum. This shows how much we had to dig deep into our already constrained budget. Honorable Chair, you must remember the Eastern Cape province is the province with the most facilities, about 900. Is the most rural province, is the most impoverished province, and is the most hard-hit province when it comes to medical legal claims. So our situation is dire and is being made to be worse off by the load shedding. There are two immediate consequences of this. Firstly, diesel is expensive to run the generators. Secondly, the generators are being used more frequently than anticipated, preload shedding. As a result, it is not unusual to receive reports that parts of hospitals are being plunged into darkness because generators have broken down through overuse. The increase in load shedding also affects our sensitive medical machinery and equipment, with suppliers of generators and medical equipment generally located outside of our rural province and parts often sourced from overseas. There are delays in effecting repairs, and this also affects the continuity of service delivery. Contingency measures we have had to introduce include transferring patients out of facilities, diverting patients requiring emergency care to other facilities, increasing the patient loads at those already strained facilities, and moving patients further away from where their families live. Another challenge, especially at stage 6, is interruption in water supply. We have hospitals that receive their water supply through electrical pumps from rivers in rural areas. When the electricity is down, the water does not flow into the water reservoir or into the reticulation adequately. Once the electricity is stored, the water resumes, but at one facility, before the water can be pumped to the foot of the hill and up towards the reservoir, the next load shedding stage kicks in and no water reaches the reservoir. When water supply is affected during high stages of load shedding, the department has had to arrange cutting of water to the affected facilities and install water
Missy?
water cutters to access, and in some instance systems so that the water from the borehole can be utilized. Cutted water is really expensive, and there are often challenges obtaining and transporting water to facilities in deep rural areas. These various scenarios place the facilities in a difficult position because we are in the business of saving lives and preventing deaths, where every second and every minute counts. We are fortunate that no one or no report has yet been received on the loss of lives, and that we have been able to put contingencies in place to anticipate and deal with every situation and that arises. However, Honorable Chair, this is not an ideal situation. The Deputy Minister was spot on, or the Minister was spot on. Continuing unabated, interrupted power supply. In the next phase, I cannot fully power supply. Elective surgeries have had to be put on hold in some facilities, adding to the backlog we are trying to catch up on post-COVID-19 backlog. Honorable Chair, we have been proactive and engaged some municipalities to exempt our facilities from load shedding. Nelson Mandela Bay was the first municipality to exempt facilities with life-saving machines from load shedding under the collective leadership of former Executive Mayor Johnson. These are Livingston, PE Provincial, Uitenhage Provincial, and Joseph Pearson hospitals in Nelson Mandela Metro. Furthermore, Frey Hospital in BCM and Elliot District Hospital in Krisani have also been exempted from load shedding. Chair, we have submitted a list of close to 17 hospitals to be exempted to the national department, but unfortunately only 6 are exempted. We are hoping the negotiations at a national level with the support and recommendation from the National Health Council to have more facilities exempted from load shedding will yield the desired results so that lives can continue being saved and we can give greater assurance of service continuity. We welcome the declaration of load shedding as a disaster by the National Department of COPTA. This will enable the department to access appropriate budgets reserved for disasters under the infrastructure program. Our engineers have undertaken a technical exercise to identify appropriate interventions to further minimize the impact of load shedding. This includes such opportunities such as use of alternative renewable energy sources like solar and wind technologies. The department is collaborating with NGOs for the installation of solar power units at various clinics, and technical investigations will be commencing soon once the MOs between the department and donors are signed. Honorable members, we agree with the SA Medical Journal Literature Review, which looked at the possible impact of load shedding on the healthcare sector and predicts increased patient loads as people start using unsafe sources of energy, e.g. paraffin, gas, petrol, wood, and plastic. Fast deteriorating hygiene and infection control, including through poorly maintained and flood and power loss impacted sewage systems, an increase in foodborne disease, plus compromised hospital temperature control, sterilization of equipment, and UV light sources. The SA Medical Journal Literature Review further predicts that also jeopardized would be the cold storage of products, medicines, and bodies, resulting in mortuary problems with burial delays, faulty clinical devices and backup batteries, forced manual interventions, aggravating staff shortages, and compromising the mental health and hard-pressed healthcare workers. Immobilized hospital elevators would restrict the movement of patients and staff, while diagnostic services would be hard hit, including the complete loss of radiological and pathological amenities. Communications and administrative services would be imperiled, while hospital pharmacies using electronic scripting and dispensing would see increased backlogs in medical scripts. The management team have noted the journal article and notes that some of the scenarios have emerged. And as an example, we have had to invest in electronic temperature gauges to ensure we are able to monitor the temperatures of various types of fridges that house medicines and other health-related products. The theft of copper cables at our facilities further exacerbates an already difficult situation. And honorable members may recall 2 of our facilities, Frontier and Cecilia Makiwane hospitals, just last month had to contend with cable theft, load shedding, and generator challenges affecting the continuity of power supply. The teams at the facilities work restored. As I conclude, Honorable Chair, we are doing our best to ensure that facility managers are ready with these various interventions to provide electrical supply during load shedding, and that they are. It is a
Let me see. Thanks, Honorable Meth.
So,
Honorable
Chair,
Mem.
I've got cut. I was just finishing, Chair, if you can allow me just 1 or 2 minutes. I was saying
Yes.
regretfully, the suppliers on the national diesel tender are not always able to deliver diesel to our rural facilities, seemingly prioritizing larger orders of bigger hospitals.